Welcome to UO Today. I'm Barbara Altman, Director of the Oregon Humanities Center. Our guest today is Jessica Greene, Associate Professor and Director of the Master of Public Administration program in the Department of Planning, Public Policy, and Management. Greene's research focuses on the role of individuals in making informed health and health care decisions and the impact of changes in the healthcare system on access and quality of care, particularly for vulnerable populations, including the poor, people of color, and older adults. She has written numerous peer-reviewed articles about health policy for the American Journal of Managed Care, Health Affairs, and Medical Care Research and Review, among others. Greene is the principal investigator for a project entitled Increasing Mental Health Access for Low-Income Pregnant and Postpartum Women, funded by the Northwest Health Foundation. Jessica, welcome to UO Today.
Thanks for having me.
We're really glad to have you come to speak to us, especially as the healthcare debate is raging across the nation. You're a woman who must be in great demand at the moment.
It's a very interesting time, no doubt.
Yeah. I'm going to pitch you a very big question to begin with, and it's perhaps a little bit unfair, but I wanted to know if you could summarize, as a way to get us started, what you think the major drivers of are of the rise in healthcare spending at the moment.
There are clearly a number of factors that contribute to this. One of the main ones is the technology, the amount of high-tech equipment that we have in the United States, but sort of the area that's getting a lot of attention right now is how we pay healthcare providers. So we don't pay healthcare providers for how well they provide healthcare. We provide them for how much healthcare they provide. So the more services a doctor provides, the more money he or she makes. And as a result, we have sort of a funny incentive set up. And right now there's a lot of attention to maybe trying to address that kind of incentive and change the way that we're reimbursing doctors and to try to do more rewarding of high quality, provision of high quality care.
I understand the difficulty in quantifying the quality of care and why it's easier to default to the number of services provided. But could I ask you to go back to the thing that you mentioned first, which is the costs of technology? What did you mean by that? What kind of technologies are we talking about?
In the United States, we have a higher percentage of sort of MRI machines and other kinds of robotic, Sacred Heart now has a new robotic surgery machine, that really a robot that conducts surgery. So we have more of that per capita than almost any country in the world. And as a result, there's sort of competition among hospitals to have more and more of these kinds of high-tech equipment, and that in and of itself helps increase healthcare costs.
Presumably it also helps increase quality of care.
That's an interesting question. That would be great if we knew that all the high technology really improved care. What we know about healthcare quality is there have been some major studies that have found that doctors on average provide about half of the recommended care that patients should get in any given visit. It doesn't matter if it's a chronic illness visit, an acute care visit. And so will technology solve that problem? I mean, it might do a much better job in reducing errors and doing sort of really high-tech medicine, but if we're not providing patients with the sort of baseline recommended care that they get for primary care and chronic disease care, then we still have quality problems. And as a nation, while we're spending twice as much money per capita as most other countries, we don't have better health outcomes. We literally spend twice as much as the United Kingdom, but their life expectancy rate is higher than in the United States.
Again, if you don't mind, I'd like to go back to the beginning of your answer. You said that in a typical doctor's office visit, the doctor provides half of the care that the patient should reasonably obtain for that visit. Could you explain?
Yeah, so what these studies have done is they've looked at the recommended guidelines for if somebody comes in with diabetes, what should they get when they have a diabetes well visit. and typically they get half of the things that they should get, but it's not, it's been a very comprehensive study, so they've looked at the recommended guidelines across a whole host of kinds of care, and they've done this study sort of nationally, so they've looked at it both for adults, and there's been a sort of comparable study for pediatric care and found really the same thing, that it's about half of all the services that are recommended are actually given on any given doctor visit.
So again, presumably it's not because our physicians are incompetent or unaware of what would be ideal. I assume it's driven by time pressures, which are driven by the need to increase that number of services provided?
Yeah, and the incentives and the training and so there's been an idea around trying to change what we're paying for, and instead of paying for this quantity of services, pay for quality. And as you mentioned, how we measure what quality is a real sticking point. There have been a number of pilots here in the United States trying to do this pay for performance. The UK has been the most innovative in adopting this kind of pay for performance model. And we don't, I guess the research is still out there to see how much improvement we see. But clearly we need to move in this direction where people are being reimbursed for doing the right thing. And actually next year I just learned I have the great fortune to be able to go to Australia, and I'll be looking at their pay for performance for physician program, which they've had for a number of years in operation, and I'll be able to look at sort of what kind of changes in doctor in how they practice medicine based on what they're being reimbursed for, and look at where there's been changes, where there haven't been changes, try to explore why there haven't been changes, and to look at if there's been any impact on disparities, like have the changes occurred in areas where there are more affluent people or less affluent people. So I'm very excited to be able to go on a sabbatical and look at this question.
That's very exciting. So you said you're doing it as a sabbatical project,
yeah.
And you have an institution you'll be working with in Australia? That'll be great, and I expect you'll get a lot of information that might transfer back in some ways, or provide us with some ideas.
Hope so.
We started with a big question. I want to go to the big question, an even bigger one. Do you have a good answer to how healthcare can be made more affordable without limiting access?
I would say that's the $1 million question, but in fact, as we see the Senate healthcare bill costs, I think it would be the $1 trillion question. No, I wish I could say I had the answer. I wish it was that simple. I would say there's an area that is being explored and there's a lot of attention to right now, which is cost effectiveness research. So trying to better understand what approaches to treatments are effective and also relatively low cost. So sort of a good bang for the buck. So do you need what this requires is sort of getting a better sense of what's the relative efficacy of different drug treatments, different diagnostic treatments, like can you use an X-ray when an MRI? I mean, can you use an X-ray in lieu of an MRI? Clearly we know that the X-ray would be much cheaper, but how much quality are you losing in doing that? And so this is sort of the area of sort of really putting different approaches next to each other and testing how different the outcomes are, because typically that isn't done. So in part of the stimulus package, there is lots of money to do this kind of cost effectiveness research. There's a lot of political backlash around, well, okay, what if we find that there's, say, this treatment is much more cost effective than another? Will health insurance plans or will the government start saying you can only reimburse for a certain area? So there's a lot, essentially there's a lot of politics in wherever you go around trying to contain costs. Say if you were, I would say this is why you don't see a lot of real cost containment in the current bills in the House and the Senate, because there's a lot of stakeholders that they need at the table willing to support the bills, and they don't want to lose the support of the doctors by saying we're going to change reimbursement policy, and they don't want to lose the support of the hospitals or anyone else around the table. So right now, even if we knew how to reduce costs, I don't know that it would be politically feasible to have in this current healthcare bill. I think we need to get everybody in and have coverage, and I think then we're going to be in a place where we're going to really need to take some serious efforts to contain costs.
So your answer is a pragmatic answer about what needs to happen, taking all of the stakeholders into account, simply to make this first step forward. But do you have your own settled opinion about the role of government in cost containment for healthcare, what it should be?
Well, right now, as a society, we have decided that the haves can have a lot, and the people without insurance coverage can have close to nothing. It sort of depends on what state they are and how much of a safety net system there is. But we certainly have rationing. Right now, sort of the lowest income folks have the Medicaid program for health coverage, but the people just above them, a lot of working poor, really have nothing. So when I hear that there's concern about rationing of healthcare, I just always think it's important to step back and realize that, in fact, we are rationing healthcare right now. We're saying that some people some 47 million people will have no health insurance. Clearly, they have some health care. They can, they can go to a hospital, and hospitals have to treat them. But then there's sort of the financial impact of that for them. Remind me where I was going. Your question was?
I was gently leading you to state whether you have an opinion about the role of government in cost containment.
So okay, so here we are with the government. With our current system, and so where I think. I think that there really is a strong role for government in making sure everybody has coverage and regulating health plans so that the answer is there's going to have to be a role for dealing with the cost problem, because right now the government isn't really taking much of a role, but health insurance plans are. So health insurance plans say, we're not going to cover you if you have pre-existing conditions or you have too bad of a health history, therefore we're going to completely deny you coverage. So clearly the private sector isn't handling the problem appropriately, so the government does need to have a role. But what that role could look like could be different.
Got it. So basically a shift in responsibilities, and we'll see what that looks like we'll make it up as we go along.
To some extent.
To some extent. Let me go back to something that you were saying before we began recording the interview. It was interesting to me that you said that the Bush government era had a different focus in its approach to healthcare than the current Obama administration does. And one of the key words, and something you've done a lot of work on, is the notion of a consumer-directed health plan. Could you explain what that is?
Sure. So in the Bush administration, there was a real notion that the driver of healthcare costs was that people don't treat healthcare as if they were purchasing a commodity in the way we purchase all other commodities. So if we're buying a car or a dishwasher, we typically go to Consumer Reports, we look at the cost and quality of our options, and we make a choice that's best for ourselves. And so what the Bush administration theory around healthcare cost was that the driver of healthcare cost was that people were going to the doctor or going to the hospital, and they weren't thinking about whether or not it was worth their money to do so. That health insurance was sort of buffering people's decision making. They knew that they had coverage, they were going to go to the doctor, they didn't have to pay the $250 the health insurance would be covering it. So they proposed or sort of developed these kinds of health plans called consumer-directed health plans, which had a high deductible. And the deductible could differ, but say if you were a family, it might be $3,000, okay? And you had a savings account that might have been half of that, so $1,500 in a savings account. And so there would be health coverage once you hit that deductible, but for the first $3,000, you'd have to pay either out of your pocket or out of the savings account. And the idea would be that people would be more conscious of their healthcare use if they actually had to pay the costs of the care. And so I did a bunch of research along with a number of colleagues here and elsewhere, looking at whether these kind of high deductible health plans coupled with a savings account resulted in people making better healthcare decisions. Did they put off care that was of low value? So did they stop going to the doctor when it was just for a cold? And the converse, which was what a lot of critics of these plans thought, was did people stop getting care that was high value, or things that we know are recommended and really have important impacts on people's health? So did people stop getting prevention? Did people drop off chronic illness medications? And what we found was that most people didn't drop off chronic illness medications when they were on one of these high deductible health plans or consumer-directed health plans, but there were many more people in the consumer-directed health plans that dropped off of their chronic illness medications than in regular, more typical health plans. So people were making short-term decisions to save money that could have had long-term health impacts and health cost impacts.
Have those findings then had the result of backing off the notion of consumer-driven health plans? I
would say that they provided some fuel, but there was already pretty much of a political divide on this. This was a Republican sort of ownership society initiative, and the Democrats have been in opposition to it. So now once the Obama administration is in power, we're not hearing a lot about health savings accounts right now, or consumer-directed health plans.
So the focus of the discussion has changed.
Yeah.
I know that currently you're doing quite a lot of work on how to build incentives so that the individual is more encouraged to undertake preventative care. Could you explain what some of those programs are, or what your ideas on them are?
So the idea here is that people make a ton of day-to-day decisions that have huge impacts on their health. So decisions around tobacco, decisions around physical activity, nutrition, these things have really major impacts on health. In fact, the combination of tobacco, physical activity, and nutrition, those three factors are implicated in 1/3 of all deaths in the United States. And so therefore you can just imagine sort of the amount of healthcare costs that are related to these kinds of behaviors. So the question is how to get people to do more healthy behaviors. And one approach that a number of health plans and states, I've been working more around states, with states around their initiatives on this, have tried to create rewards or financial incentives, or sort of like gifts, to get people to do more healthy behaviors. And so I've been evaluating a program in Idaho where children with Medicaid who are actually, it's a little less about healthy behaviors, though they do have a healthy behaviors component, but for children with Medicaid in Idaho, if they are up to date on their wellness checkups, they don't have to pay a premium for their Medicaid. It's a small group of kids with Medicaid that actually have to pay a premium. But the goal was to try to create an incentive to get them to go and get the well child visits, and if they were up to date, then they wouldn't have to pay this monthly premium. And we've followed these kids for 3 years now, and it really seems to have made a huge difference. That the well child visits in some age groups have as much as doubled or tripled. Other age groups, among teenagers, it's been a little harder to get them to improve their well child visits, but still we're seeing jumps. So there is clearly potential to use incentives in a more targeted way to help change behaviors. The question is really how to do it effectively, and we're just starting to learn when it seems to work, and a lot of it has to do with making sure people are aware of the incentive, communicating with them often, and it not being so onerous to follow through. So for young children to be up to date on wellness visits, that means a lot more visits than it does, for kids under 2 than it is for kids from 3 to 7. And so we saw a lot more kids up to date on wellness for the sort of 3 to maybe it was even 12 age group than the younger kids. So can we use incentives to get people to stop smoking and do more physical activity? There's some evidence that it can be done effectively. There's a recent employer study that showed that with financial rewards, people were much more likely to stop smoking than if they didn't have a financial reward and they actually maintained those changes in behavior. They stayed off, continued to quit smoking. But we haven't consistently seen that. We haven't seen sort of states try to do that. The state of Florida has tried to incentivize people to participate in a stop smoking program, and they haven't been particularly successful. But I think that's more to do with sort of the difficult process and getting reimbursed and letting people know about how to do the process than about the concept of it.
So it's as much a question of communication and education and almost advertising as it is the process itself.
Yeah.
Are there incentives other than financial that might work or that anyone has tried?
Yeah, in Medicaid, which is the context I know best, there's a lot of concern about giving anybody money, so there's a lot of gift card use. Other than sort of, I guess in the Senate bill right now that's being considered, it's the ideas if people, there's a provision that would say that if people participate in a wellness program through their employer or through the state, that their premiums could be reduced up to 30 or potentially 50%. So it does seemingly all around money.
Okay. I wanted to ask you a little bit more about the project that we mentioned during the intro, which is the one on which you are currently principal investigator, increasing mental health access for low-income pregnant and postpartum women. Could you talk about that? Is that also related to the question of incentives?
Absolutely. So this is a project that's we'll be getting started in January. We're just through human subjects. And this stems from this idea of what can we use incentives to spark healthy behaviors. In this case, it would be getting mental health care when for women who are pregnant with depressive symptoms. And as I mentioned earlier, one of the potential limitations of using incentives is that once you stop the incentive, people often revert back to the prior behavior. So the idea of using incentive around pregnancy is a really appealing one because it's a finite period, and it's a period if a woman is in better health, the impact will be not only felt by her, but potentially also by the fetus and eventually child. And so I'm working with a group, Health Policy Research Northwest, here in Eugene, and we're collaborating on this project where we're going to be working with, again, people on Medicaid, women on Medicaid, and we'll be screening them to see if they have symptoms of depression, and if so, they will be have the opportunity to participate in the study where they would be randomized to get the incentive for going to mental health visits or not. So we'll be able to see how effective that is.
And I did hear you say that this is both for the well-being of the mother and the child. Yes?
Possibly, yes.
How did you identify the mental health component of their care as opposed to other possible aspects?
Yeah, this was a collaborative project, and so the folks at Health Policy Research Northwest were very interested in the mental health part. I was interested in the pregnancy part, and so we sort of came together, and this is where we ended up.
I see. What is the timeline on that kind of an investigation?
That's a good question. I believe it's a 2.5-year study. So we'll be starting to recruit in January, and it's going to take us a while because while there are a lot of women in Eugene with Medicaid, the number who are pregnant and who are going to be able to contact, it ends up it's going to take us a while to get the numbers that we need.
Yeah, that makes perfect sense. I was looking at the number of public presentations you give and thinking about the role of being both an academic and someone very active in policy setting on a topic that is of raging interest across the country at the moment. So you speak to a lot of university groups. You've gone to any number of institutions across the country, including your alma mater where you did your graduate work, the NYU's Wagner Graduate School of Public Service. But you also end up speaking to a lot of public policy institutes, probably nonprofits. Could you talk a little bit about your role, how you see your role as a public intellectual in this field?
It's an interesting question.
It may be an unfair question. If I've put you on the spot, feel free just to say no.
You know, I think maybe rather than answering that question, one thing that's been very interesting to me has been bringing this policy topic to the students here at the university. And last spring, I taught a class in the Honors College around healthcare disparities, racial and ethnic disparities in healthcare. And that was actually one of the most satisfying teaching experiences I have ever had, because I was teaching about sort of some of the factors that contribute to the racial and ethnic disparities we see really consistently in healthcare outcomes. So we consistently see African Americans doing worse than whites on, measure after measure, even when we control for differences in income. And it enabled me to bring history to these students, psychology of sort of our people's, how we categorize and have implicit biases about people. And so it's been amazing for me to be able to bring some of these topics to students and actually have them really embrace them and get excited about them. And I had students really say they were going to be better doctors and nurses and psychologists because they now were more aware of the issues of inequality in the United States, and they just had this passion to try to address it.
It makes sense to me, and it makes sense to me that even those who aren't destined to become doctors or nurses or psychologists may become better informed consumers and vote differently as a result of this kind of education. We're going to have to close there, Jessica, but thank you very much for coming to talk about this.
It was a pleasure. Thanks.
We've been speaking with Professor Jessica Greene, Associate Professor in the Department of Planning, Public Policy, and Management at the University of Oregon. Thank you for watching, and see you next time.